Hello, future PTAs. I hope you guys are doing well. Today we are going to talk about pediatric positioning and handling. So some of the positioning goals are to improve head and neck control, accommodate for muscle weakness, provide proper postural alignment, manage muscle tone and extensibility, and provoke independent movement. All the activities and goals basically focus on increasing function and encouraging play, which is really important. So the ultimate goal, as I said, is to improve functional movement and independence. We're going to discuss further some positions that you can put patients in, or specifically pediatric patients, to help provoke different activities and things. So we'll discuss all those positions shortly. Some of the common pediatric impairments are low muscle tone, abnormal sensation, decreased range of motion, weakness, impaired coordination, and they are more likely to get contractures and functional limitations if they're not positioned properly. So when we're talking about pediatric positioning, we're talking about how you place them down when they're not in your arms, or even how you hold them when you are holding a baby, whether you're feeding them or just transitioning to and from a car seat. Just how to handle them in a way that's therapeutic and helps them reach their goals. One thing I want to mention is that children with neurodevelopmental disorders demonstrate delays in play. So typically they're not playing at the age expected level. They're not as imaginative or have more difficulties doing pretend play compared to same age peers. So play helps children develop emotional intelligence, social skills, cognition, language. And so it's really key in their development. So we always, for one, it's hard to get a child to do anything without incorporating play, but it can even be like one of the goals that they'll play with a peer for, however long or whatnot, especially with OT or some other therapies, because it is so key in their development. And as far as positioning goes, one thing to keep in the back of your mind is, in general, a child with low tone and with joint hypermobility needs stability. So you need to position them in more stable ways or add some stability, whether it's through adaptive equipment or something like that. Whereas those with increased tone or limited range of motion need more mobility, like mobilization, whether you're stretching them or placing them in positions that do stretch them. Being mindful of that. So just like the overall arching theme that we've said in all of our patients, if it's tight, stretch it. If it's weak, strengthen it. If it's unstable, stabilize it. And if it's immobile, mobilize it. Same thing with pediatric patients, but it's really important for them because they're developing all their muscles, they're developing all their joints, they're developing all their skills. And if you do not stretch it while it's developing, it's going to get very tight. All right, here is our posture pyramid. As a child gains control, their base of support becomes smaller, more narrow. Those with poor balance have a wider base of support. One of our goals in therapy is to decrease the arm support needed so that they can free their hands to explore their environment. Exploring their environment is one of the main ways they learn. So it's really important to allow them that opportunity to explore their environment. And if freeing their hands up so they're not propped up on their hands when they're standing or sitting does that, then we need to focus on that as one of our goals. All right, so several of the positions you can put a child in. Supine. This is the easiest and first position that they typically master. It allows them to reach with their hands, to look at their surroundings. It's a good base for rolling back and forth. It's also good for feeding and for changing diapers. I mean, it's a really key position in the earlier stages of life. And you can see this baby quite loves it. So prone is our next. Tummy time is really important. They've been, kind of promoting tummy time for the past, for many years now, probably 20 years or so, to put children on their tummy to help them develop their core muscles, especially their muscles in their shoulders and their hips, and eventually in their back and stomach. And some of the progressions is at first, just like this baby in the top corner that can't quite lift his head all the way off the mat. Of course, you have to be really careful about that so they don't smother. You have to put them either propped up on you or in a position where you can start tummy time, but safely. Eventually, they're able to strengthen the muscles in their neck to lift their head off the tables. Then or the mat, they're typically able to push up on their elbows next, and then eventually to extend on their arms like the baby at the bottom, and ultimately push up onto all fours, which is a more functional position to prepare for crawling. So prone is great. It's great for strengthening the shoulders, hip, and the core. It is a good position for rolling and to start crawling. And it's really good for proprioception because you have that joint approximation. Remember where the joints are getting that weight bearing and kind of getting some compression. That's what the approximation is. And that gives the brain a lot of feedback about where your body is in space. So it is really huge for babies to crawl. So some parents will brag, oh, my son never crawled. He just went straight to walk in. A lot of times that happens in children who have low tone because they don't have the core strength to crawl, or they don't have the perception or even the tolerance for certain positions to be able to prepare for crawling. So even in children who are already walking, I do crawling exercises and activities because it's great for the core muscles, especially for children, patients that have skipped crawling, that have never crawled. One sign that they may have weakness, even if they are crawling, is if they do that commando crawl where they're laying on the ground and they're doing like an army crawl, because typically they don't have the strength to pull the core up off the floor, and that's why they're doing that belly crawl. But even my older children, I've seen great benefits from them crawling, like even before sports, having them crawl around and do a little activity. Then you'll notice their hand-eye coordination is improved, and their ability to focus is improved. So it can really help in a lot of different areas. Okay, sorry, my computer's lagging for some reason. So sitting is another position, and it is a great position because you're upright, your eyes are level with the horizon, your mouth is level, in a good feeding position. The head is upright. This is one of the key positions for self-care, for feeding, for play, for exploring the environment. Most normally developing children will be able to sit on their own somewhere around the 6-month age period. But they need enough trunk stability and neck strength to hold their head upright and to stabilize themselves. They may or may not need external support, either holding themselves up with their arms or maybe you holding around their belly to help them get to that position and work on strengthening towards that position. Or there are certain adaptive equipment that they could sit in that could offer a certain amount of support as well. So the higher the seating device is, the more support it gives, and the lower, like if it's just around the waist or the hips, the less support that it's giving and the more they're doing on their own. This position is good for exploring the environment. They may even be able to scoot around in this position. And it's one of the most difficult positions to get in and out of. So going from sitting to all fours or to side lying or even backwards, unless they just throw themselves back, are very good strengthening positions. So it's great to practice those transitions to and from sitting because it is a difficult task for a child to do, and it's very good for strengthening. All right, quadruped, not to be confused with quadruped. I had a patient call it quadruped in the past, but it's quadruped. That's when you're weight bearing on all four extremities. Of course, the weight bearing itself is good. It helps calcium absorption. It helps long bone formation. It also helps with that proprioceptive feedback to your brain. Any joint approximation can help with that and is really good in the developmental process. Quadruped is the basis for crawling and is extremely helpful and good with strengthening the core and as well as the proximal muscles. Promotes that proximal stability, promotes core strength and stability because the trunk is actually working maximally against gravity in this position. So even for adults, some of the core strengthening exercises you can do is that quadruped, opposite arm, opposite leg extension, where you're on all fours and you're doing one leg at a time in the opposite arm. So, even for adults, it's good core strengthening position to be on all fours like that. I will say that I'm not in 100% agreement with the book on this. They say that this is a dependent position because the limbs are flexed and they said the head isn't always upright, so they call it a dependent position and say that it's been omitted from the pyramid for that reason, and that it's often omitted from therapeutic goals, and that they're saying that it could lead to more joint contractures because their hips and everything are flexed. However, I would strongly disagree. I would say this to me is one of the most important positions because it is huge in strengthening proximally, and you have to strengthen proximally first before you have good distal mobility, proximal stability before distal mobility. So if your shoulder is not strong enough to support the cup you're holding, then you're not going to have a good ability to grab that cup, bring it to your mouth, and successfully drink because you don't have the shoulder strength. So this is a great position. I would not leave it off of my goals or off my therapeutic, toolbox at all. I personally don't feel like most people who are at the highest risk for developing contractures can't tolerate this position anyway. So I would not worry about a child developing contractures if they're crawling around. I mean, they're getting a lot of movement, they're getting a lot of strengthening, and then you just make sure that sometimes they're in positions that stretch their hip flexors and their knee flexors so that they don't develop those contractures. But if they're crawling around, most likely they're not at a high risk for that anyway. Standing is the highest level of functional positioning, typically develops around 9 months. I feel like the book is really generous about these milestones. If you see in like the score builders and stuff, these milestones really are a range. So it's good to have like a direct, around 9 months to remember in your head, but there is a range of normal development. And I would say, every child is a little different. So if they haven't developed it by right at 9 months, it's not necessarily a bad thing. But this standing is huge. It helps bone mineral density because anytime you're in a weight-bearing position, your bones reabsorb more calcium. It helps with range of motion, with hip stability, and with decreasing spasticity. Any of that deep pressure can help with your brain know what's kind of normal for your arms and legs. Of course, standing, it's primarily your legs, and help you develop more normally. It enhances exploration of environment, which is huge for children, and it is the foundation for walking. So most children, the book says most children are walking by 12 months. The range typically now is suggested more so like 12 to 18 months. So before, if somebody wasn't walking by 18 months, they felt like they were delayed. Now there's more of a range where, different children just do it at different stages. But walking significantly increases the ability to explore the environment and is often a therapeutic goal. The book was mentioning that a lot of parents, walking is somewhat seen as a sign in society of fitting in or just being what some might call normal. And so they say a lot of parents, that's just their biggest thing. Like, will they ever be able to walk? When will they walk? How can we get them to walk? That's like their biggest goal. And that many parents have said, evidently to the therapist that wrote the book, that it would be more important to them for their child to walk than talk, because they just felt like they'll fit into society more. And so that's just a really interesting perspective that the book points out, that this is a huge goal for parents, for kids, for, just fitting into the community. And one of the things I've read studies about eye contact, how important eye contact is, and that people who are restricted to wheelchair mobility really miss that because they're not on eye level with people as they're walking around and engaging in social activities. And so it is really important to have that eye contact, whether you get down on somebody's level or you bring them up to your level, especially in children as they're developing and getting their confidence and their personalities and their idea of what the world is. So standing, walking is huge for these populations. Right. Some of our interventions, so you want to incorporate positioning into their daily routines. Of course, sitting is one of the most functional positions, and you want to educate caregivers on ways to handle the child that enhances their eye contact, that gives them security so they don't feel like they're falling or they're not scared in the position, but it also allows them to interact with their environment. Of course, we change positions often for a child. I mean, we ourselves, as we're sitting in chairs, we change positions often. That's how you don't get pressure sores. But it's really important for a child to change positions often. I have heard many people suggest that infant should be should like if they're dependent and you're putting them in different like swings or slings or standards or whatever as they're developing, that they should be moved every 15 minutes. So that's not necessarily something you need to memorize. It's not from the book. It's just been suggested. And I've heard of daycares following those suggestions of kind of repositioning and moving kids around every 15 minutes or so that they can look at something new, or they can look at different direction, or they can work on a different muscle group. So it's really important in development. The upright position stimulates more social interactions and more exploration of the environment, and that's how they learn. So exploring the environment is something I'm going to repeat over and over because that is how we learn, and that's huge in developing a child and developing not only cognitively, but also their confidence and their self-esteem. So that is really big. Head control, just on a different note, develops typically around 4 months old, and this is a necessary foundation for performing functional tasks, especially in the seated position. If they don't have head control, then they typically aren't able to sit independently, of course, but even maybe with some help, they're really going to need a lot of help, even supporting the head. And so if they have good stability of the trunk, like if you are putting them in a position and really stabilizing the trunk, sometimes they are able to stabilize the head themselves, but the less help you're giving them, the harder it's going to be. If by 6 months a child is not able to sit on their own, then it would be ideal to have some type of sitting equipment. It doesn't have to be special equipment that you ordered through your insurance. It could be like one of those, they used to have those boppy seats that got recalled, or certain like high chairs or swings or whatever that you have around the house, so that they're able to start working on those muscles and be in a more upright orientation to the world, and they're able to sit at the table with the family and have those social interactions and begin assisting with feeding themselves and things like that. That's key to their development. Home program is huge with all of our patients, but especially pediatric patients. One thing that I want you to remember, and I don't think I have it on this slide, but I have it written somewhere, is that a lot of these parents are overwhelmed. So if you are a parent, you may remember the first, for me, it was first year of my first baby's life, but the first 6 months of a baby's life being a new parent is super overwhelming. All of a sudden you're waking up at night and there's a little being that's demanding attention continuously. And it's a lot. And people don't always warn you about how much it is, but it's a lot and it's a great thing. But especially if your child has any extra needs, like maybe they aren't, they're having difficulty feeding. So you have to do extra things to get them to latch on, or even maybe a feeding tube, or maybe they are having a lot of reflux. And so you have to make sure they're sitting up for 15 minutes after every bottle, which sounds like nothing. But if you are feeding them every 2 hours and it takes them 20 minutes to eat because they're having difficulty swallowing, and then they have to sit up for 15 minutes, well, you only have an hour between finishing one feeding and starting the next. And it just feels like it consumes your whole life. So remember that these parents oftentimes are already very overwhelmed, especially if they have any other kids, especially if the child seems to have any issues with their development or with their feeding or with their, um, you know, muscle tone or anything like that, then they're even more overwhelmed. And so when we give a home exercise program, we're not saying go and do this and hold this stretch for 5 minutes or do this 30 times and do it 3 times a day. We're not doing that. We're saying, okay, when you're changing the baby, pull their legs out to the side and stretch those tight adductors. When you're holding the baby, make sure you hold them on this side so they're looking more to the left because their muscles are tight and pulling them to the right. When you are carrying the baby from one place to another, make sure that you're interacting with them on this side because they're ignoring that side. Whatever it is, it goes into their daily routine. You want to teach them how to incorporate therapy into their normal environment because otherwise they just won't and cannot do it. It's got to be more of a lifestyle of, as you're doing the things you have to do anyways, feeding and changing and holding and playing, here's how you incorporate a stretch or a, activity that strengthens or whatever the goal is. So it needs to be part of their daily routine, acknowledge their demands. Okay, it is kind of on this side, incorporate it into their diaper changes. And always with any home exercise program, pictures are a great reminder because people forget. It's hard to remember, anything, but it's especially hard to remember things that you haven't necessarily been trained in. If you've just learned it in 10 minutes, it's hard to remember exactly what they said once you leave the therapy session. We want to educate the patients and the caregiver on positions that are functional, on how to handle the child at home, on positions that they can carry the baby in or hold them in that will encourage whatever therapeutic goals you have, and on techniques for helping the child move, how to handle them to help them become more independent and to encourage them to start moving on their own. Some of the positions for functional or for function. So you want a position for alignment. You want to make sure they're comfortable and they're well supported. You want to prevent any deformities. So if they're tight in this area, you may want to make sure you focus more on positions that stretch that area. If they're weak in an area, you may want to prop them up so they're not, tilted or slumped or whatnot, depending on their needs. And you want to provoke mobility as much as possible, even if it's just that they're able to move their arms and access their environment that way. But especially if they're able to freely get from one place to another and explore their environment, that is huge. That's what you want. Some of the considerations, often children get tight heel cords. This is the Achilles tendon, but in children, whatever reason, we always call it a heel cord, but it is the Achilles tendon, and it often gets tight in children, and then they may start out as toe walkers and then it becomes tight, or they may become toe walkers because it is tight. And so that's huge, and getting them to develop a more normal gait pattern is stretching those heel cords. Hip dislocation can be a thing, especially with somebody who had hip dysplasia. So you have to be careful what positions you put them in, depending on if they had that. Supporting the spinal curves is key as they're developing so that they don't start to, if they're weak on one side and always slump into that side, they could develop scoliosis or whatnot. One of the positions we discourage is W sitting, because with W sitting, all their stability comes from their leg position itself. It doesn't come from the core having to do some work. And so it kind of just encourages continued weakness. It doesn't develop those muscles as they need to be. I've also understood for a while that it is a hard position on your knees. I don't see that in the book, but that has always been one of the reasons that I also discourage W sitting, is it's just not a great position for your knees to be in as you're developing either. Side sitting can be used from time to time, especially if you're sitting with, side sitting to one direction and then switching to the other direction. However, you have to be careful, especially if they have weakness on one side or if they already tend to pay more attention to one side, like neglect of the other side, that they're not always just sitting towards one side, because then they can develop some muscle imbalances that would be difficult to retrain as they get older. Whatever habits that we develop now in children as they're learning the skills get harder and harder to unlearn as they do them more. So we want them to learn the skills in a good way now so that they develop good habits and don't have to unlearn them later. We want to make sure the patient is safe and can explore their environment as always, and allow for them to weight shift and transition from one position to another when possible. Weight shifting is kind of the beginning of that transitional period and huge for mobility and for strengthening. Allow them to do as much movement as possible and to initiate as much of it as possible. So if they're already reaching for a toy, then maybe move the toy out a little bit and see if they can scoot towards that toy. Kind of allowing what they are already interested in to kind of direct how you encourage a movement. Holding and carrying position. So we've already talked about for children with lower tone, they'll need more support. So you have to be careful how you carry them. Often prone is hard to tolerate. Some kids hate tummy time, especially if they're weak, but sometimes they'll tolerate it better if the parent is holding them. So in that bottom right picture, she's just kind of like swinging them back and forth like Superman and prone. I used to carry my babies just laying on my arm in prone. I think I have another picture on a different slide that shows something similar. And they would be, mine loved it for whatever reason. They would be in that position all day if I let them, but just laying them on their stomach, after a little while, they get super tired of it. And some immediately start crying. So sometimes that's better. Another thing I used to do was bend my knees up and lay the child on my knees. So like if this was my knees, I would lay the child on my knees so that they're not all the way flat in prone, but they're kind of propped up, and it helps them develop the muscles in a position with less gravity pushing down on them. So I would start with that and tell parents to do that, and then gradually lower your legs a little bit so it's harder and harder. If their adductors are tight, then you could carry them on your hip, like the girl on the left, or even the dad over here that is carrying them facing away from him, but has his legs kind of spread out like a stretch for the adductors. So, just depending on the goals for the child. I always liked, as they got older, carrying them in this way that the dad is carrying in the top picture, where they're facing out, because then they could see their environment. And a lot of times we're more happy when they're younger. I usually face them towards me. But every child is a little bit different. But it's good to change the positions, and especially switch which side that you carry them on, because if you always carry them on one side, then they're always looking in one direction. And it could actually develop some muscle imbalances in their trunk and in their neck muscles because they're always rotated towards the same side. So then if you switch and then they have to rotate towards the opposite side, it can help balance that out. Positioning and handling interventions allow a child to move as much as possible. They encourage head control. We do not want to pull against spasticity or stimulate any other spasticity when possible. We also want to avoid some of the positions that would cause infantile reflexes if that's keeping them in kind of a holding pattern that could cause contractures or anything. You want children to weight bear, especially if they have the apoptosis is that involuntary writhing movements. It's common with children with cerebral palsy, but even if they have low proprioception or low tone, weight bearing is great for all of those things. Prone is key. Put them in prone as much as they tolerate. Just understand they're not going to tolerate a lot, especially if they have low tone. Be careful with your hand positions, because where your hands are positioned either offer them more support or less support. So make sure you're intentional about it and not just carry them how it feels natural, so that they're getting, a good amount of support or chances to strengthen when that's the goal. And as they get stronger and stronger, let them do more and more. So don't just coddle them and keep them completely supported all the time. Let them start to develop their muscles. Weight shifts, as I mentioned earlier, are the beginning of learning selective motor control. So it's kind of the beginning of learning how to walk, of learning how to free one hand to grab something. So weight shift is a really good start as well when you're working with a child, whether they're in sitting or they're in prone, quadruped. Weight shifting is great. You want to use some sensory input to promote some positioning and handling and development. So touching a child is key. They need that touch and that stimulation for normal development. You want to promote some vestibular input so that they get used to movement and can tolerate movement. Joint approximation, doing those pushes on the joint or weight bearing is huge for proprioception and for bone development. Stimulating them visually or through sound or things. Children need a lot of stimulation. So remember that. And, some get overstimulated and they need to back off from it, and that's fine, but they need a lot of stimulation to learn and to grow. One thing I wanted to mention is this picture. The man is spinning the baby around by their arms. And although that might be a common thing that people do, like spin around like that, or sometimes two parents are on each side of the baby and holding them and like swinging them through, be very careful before age 3 of pulling a child's arm in that direction, like just pulling it out right like that, because the ligaments in their elbow are immature and their elbow can easily dislocate if you're pulling on it like that. It's called nursemaid's elbow. And I've seen it happen before where somebody, was swinging a child and their elbow dislocated. So you have to be really careful about that. It's as fun as it is for the kid. Be careful. On a different note, children with hypersensitivity may need to be desensitized. This is going back to that vestibular input. So if movement bothers them, you want to do just enough to kind of irritate them a little bit, but not make them cry, and gradually do more and more movement. I had a patient once, it was a grown person, but he had some mental disabilities, and he got to where he could not tolerate riding in a car because the input it was during COVID. He wasn't riding in a car. So when he started going places again, he would scream and yell the whole time he was in the car and freak out. And so I started putting him in like an office chair. And first I just started by like rocking him back and forth. And then eventually I would kind of push him forward and pull him backwards. And then I would run him forward and run him backwards. And eventually, and this is over several sessions, this is not all in one session, I got to where I would spin the chair. And then I would do figure eights, running around figure eights. And it got to where not only could he tolerate riding in a car, we eventually went to a swing too. He did not like the swing as much, but for younger children, often a swing is great. That's great vestibular input. He got to where he actually was able to ride in a plane. That was kind of his family's goal. They wanted to go to Florida together, and he was able to go and tolerate the movements of the plane eventually. So it was very successful. And I find that most times if you start slow and just careful how you progress, that it can be successful. So some of the things for vestibular input: swinging, crawling, using different play equipment. All of that is great for all kinds of input, touch, vestibular, vision, hearing. You can do body squeezes where you're going and just systematically squeezing, just deep pressure all down their arm. You can do deep hugs where you kind of get behind somebody. All these are approximation and are really calming for a lot of children, especially if they're overstimulated. So deep hugs, and you can do just joint approximation. If they can't weight bear, you could just push their joints together. Usually I use both hands and kind of push together, but it's so I can show you on my own arm. I'm doing it that way. And all of that gives some great feedback and can help with that input. All right, so we're going to go through each of these components for preparation for movement. So with postural readiness, this is the ability of a muscle to exhibit enough resting tone to support movement. A child will demonstrate this when they're able to sustain a certain position during a task without becoming, too tired to stop. Avoid positions that provoke tone or provoke reflexes. We're going to look at table 5.1 in the book that shows kind of advantages and disadvantages of each position so that we can get familiar with those and do a lab activity in lab about that table, because each position does have its own advantages and disadvantages. Posture alignment, you want to make sure the pelvis and the trunk are in a neutral alignment before you really initiate extremity movement. So you may have to reposition and support in certain ways if they're leaning, rotated towards one side, or if they're slumped over, before you really provoke the movement. Remember proximal stability before distal mobility. So always stabilize before provoking movement. If the child tends to lean or rotate to one side, again, promote neutral alignment so they're not developing one side of the core more so than the other. Manual contacts, this is where you place your hands. If you want to add more stability, then you are more proximal, like on the hips or on the trunk, and you can guide the movements and you can reinforce the movements. But as the child becomes more strong and able to move more independently, then you can move your hands more and more distal towards their knees or arms, or it just depends on what position they're in, so that they have more control and more mobility and more rely more on their own muscles to move. With rotation, oftentimes we do some slow rhythmic rotational movements of the trunk, maybe even the extremities, to help decrease muscle stiffness and prepare for movement. So we start proximally and then we go more distally, and it's often like in the picture, she's kind of rolling side to side, but often we'll kind of keep the shoulders flat and roll the hips one way and roll them the other way, and kind of just go back and forth rhythmically and slowly to kind of help prepare for specifically trunk movements, but also full body movements. Here are some positions that provoke head control: prone over a bolster or over a parent's arm, supine on a wedge. You can't see it the way it is, but they're kind of propped up on a wedge to start promoting more and more head control. Other things for head control, the modified pull to sit maneuver. That's what's happening in this bottom picture here, where you grab the baby's arms and help them pull up. And if they don't have enough strength, their head will just kind of lag behind them. But as they start to develop strength, they'll kind of pull their head up with them. And it's a great strengthening exercise for the baby. Weight shifting from supported sitting or from any position is good. Upright, sitting, standing, anything against gravity is good for head control. Carrying them in prone or anything in prone is great for neck strengthening and head control. Upright, prone in a hammock. I don't know where the book got that one, but I feel like it screams smother. So be careful with prone in a hammock. All right, for trunk control, some of the positions to help with independent sitting, they can sit with their arms propped forward on both hands, one arm propped forward, arms propped laterally on one or both, sitting without any hand support, which was ideal so that they can play with toys. They could sit kind of leaned over, propped on one arm, and they could still side sit without any support as well. So all these positions are good to practice for strengthening positions. With transitional movements, so these encourage trunk rotation and trunk control, and some of them are rolling from supine to prone. You can often just kind of twist a baby's legs, their lower half, and their upper half will just follow. So that's sometimes how I help teach them how to roll over. Come into sitting from supine or from prone or from side lying. Anything going back and forth from one position to another is great practice for a child and strengthening, and help them dissociate so that they're not moving all four extremities at the exact same time, but they can move more intentionally. And and that helps them develop that selective motor control where they can reach for something and grab it and not just move as a unit their whole body. Here are some little suggestions on exercises to help them get into that quadruped position or transition from sitting to prone. I really like this roll here or even this mat here that helps them with that. So some movements that encourage trunk rotation and trunk control are the 4-point to kneeling. So from hands and knees to kneeling, this is short kneeling. This is tall kneeling where you're up on your knees with your hips extended. It's very good for trunk control. Half kneeling here is very good for core strengthening and trunk control. And then it's also kind of the basis to go to a standing position. So it's great for that as well. Adaptive equipment, so the supine and the prone postures with them, you might want to use those postures to encourage head control, to encourage symmetry. You can use wedges. You could use other adaptive equipment. There's plenty out there. When possible, have them try the equipment out before they purchase it. And always remember that there's a lot of barriers to them getting new equipment. Maybe they don't have enough room in their house. Maybe they don't have enough money to cover it. Maybe their insurance doesn't cover any of it. Maybe they feel like it is an eyesore and their child would get a lot of negative attention if they were seen wearing it or using it. Maybe their child has a lot of behavioral concerns and they're afraid they're either going to hurt themselves or that they're going to act out if they try and use it. So, be very understanding with parents because there's a lot to consider when they're considering different therapeutic opportunities, especially with adaptive equipment. Remember to avoid side sitting, W sitting, and alternate the positions frequently to avoid certain muscle imbalances from occurring. So when somebody is sitting in their sitting posture, you want their feet, knees, and hips all around a 90-degree flexion. When possible, neutral pelvis, maintain the spinal curves, support the trunk. The more you support it, the more more head control they have if that's an issue for them. Sometimes propping their arms on a lap tray may give them some more support. Sometimes you could have a sitting device, like even a bench that's adjustable height so that you can get it to the right height for them so that they are in that 90-90-90 position, and make sure you're encouraging them to transition in and out of various positions. Standing is huge. It has great psychological benefits. Remember that eye contact and feeling like you're on an equal level with your peers is huge in development of personality and of confidence and emotional intelligence and social interaction. So that is huge. Even if they're in a stander or using equipment or you're holding them at eye level, sometimes getting them at eye level is great. Standers are good. Reverse walkers are typically used in the pediatric population to discourage that anterior trunk lean that we often see in elderly people who use walkers and encourage more hip extension so they don't get hip flexion contractures. So typically we use a retro walker or a reverse walker that's behind them versus in front of them so they're not tempted to lean forward and develop that contracture or that anterior trunk lean. Another benefit to standing, it promotes that long bone development because of the weight bearing and can free up their arms for play and for self-care and for social interactions. Here are some of our goals for adaptive equipment. You want it to support the best available posture alignment, facilitate function and mobility, provide mobility and encourage them to explore their environment, increase opportunities for social and educational interactions, improve participation in the classroom and or at home, and then improve physiological functions and increase comfort. So all of these are some of the goals that we take into consideration when we're choosing what adaptive equipment to use and even what position to put a patient in. These are just some activities and suggestions on different positions that are therapeutic and how to use different equipment to help promote core strengthening and upright position, standing, stretching the legs, exploring the environment. All these are great things that you can use in the therapy. So I will see you guys in lab, and we will go over more ways to position and practice these. Have a good one.